And then I know
Well,
Jen is coming. I was just texting with her a little bit ago. I wonder if she's just having an issue to getting into Zoom or something like that. So she should be joining shortly.
why don't we begin with introductions with Brian and myself because we know Jen. That way, when she comes, she can hear about you. Is that okay?
Yeah, sure, sure.
Thank you. So, Brian, why don't you go ahead and start?
Great, thanks. Yeah, so it's so nice to meet you all. I'm Brian Garvey. I'm a family medicine and preventive medicine physician. I work at OHSU, an academic health center, and um, I've held a number of different roles here. Currently, I'm a program director for our public health and general preventive medicine residency, and also am involved with the sort of the greater education mission with our group and also do some research in the addiction space. I've been doing addictions work for many years now. So yeah, it's just a little bit about me. And I've been I'll just say have been working in Thailand mostly with Mayfalawang University in Chiang Rai. Um, Basically since I think 2018, Justin, is when when I first tagged along with you. So have been working in Thailand. I usually come a couple times a year and have been coming since then. And just absolutely love the opportunity. We've been in Chiang Rai. We've been helping to teach some research methods classes to School of Public Health and School of Medicine faculty, and working with the medical school there too has been an absolute joy for us. So thank you for having me. It's nice to meet you all.
Thank you, Brian. And I'm Justin. Lucky to work with Brian and have met Dr. Korapat some time ago through our collaborations between OHSU and CROT. I oversee these collaborations. I'm also a family medicine doctor and also the former director of the program that Brian worked in, and have been working with WHO for many years in Laos, Pathet Lao. And I lived in the 70s back in Thailand, went to school there at Bangkok Patana School back in the 1970s. Anyway, our program is connecting our students and our residents and our faculty with Thailand to do research, to do medical trainings and capacity building. And we have a fellowship program as well there. We are very keen to talk to you because often the requests have been around specialty trainings. But when we met with Dr. Korapat some time ago, we were very excited about your population health work and wanted to know how we might be able to work together, given the fact that OHSU has a very strong family medicine training program. And it looks like Jen has joined us at the right time. So, Jen, we're just getting going here. So, thank you for joining.
Thanks for having me. Sorry I'm late.
No
Jen, we're
problem.
just doing very brief introductions. We're kind of going all around the room. You haven't missed anyone but Justin and me, so your timing is perfect. And if you want to give a brief introduction, then that's great, and then we'll probably pass along the mic to our Thai colleagues. Yeah.
Excellent. Well, I'm Jen DeVoe. Very nice to meet you, a family physician and population scientist, implementation scientist, and have been at Oregon Health and Science University in the Department of Family Medicine for 25 years. A professor and chair of the department, and really looking forward to learning more about you and how we might be able to collaborate in the future.
Okay, why don't we start from our side too?
ค่ะ maybe
Please.
อาจารย์สุประสิทธิ์ first ค่ะ
Yeah, hello everyone. Um, Maybe I'm more senior. Um, then I'm a retired professor. I once dean of medical school at Naresuan University. I'm I focus my research on the health system and policy research and healthcare financing. Um, I'm interested in networking with the research on primary care in Thailand, which it's not, it's carry on, still continuing to see success, a big success in the future, but it has been for decades that we have not much research publications on the primary care system, especially on the healthcare financing and the impact of payment system. So that that's why I joined today because Oregon. I I heard about Oregon prioritization lists for 20 years, so it's a good experience to discuss with OSU team to see the impact of the plan. Yeah, over.
อาจารย์รามค่ะ one thing I
Hello.
would like to add on Dr. Supasit. Professor Supasit, he run a program, a medical trainee program. It's like medical education that was very successful in retention people in community. Usually in Thailand, medical degree takes 6 years. It's like it bring high school students coming into, and then not everyone come with high intention to be a doctor, including me, for example. But because we passed the exam and we trained to be a doctor because it's a well-recognized profession, and that's it. But with Dr. Supasit leadership, the program in the Naresuan University demonstrate how medical degrees, medical professionals retain in the community and in a poorly served community. And I would like to add from Dr. Subhasit CV, I learned that he has strong interest in equity. And congratulations, นะคะอาจารย์ you succeed to let people retain in the community. And these students from Naresuan University are very, very strong medical professionals. ค่ะ
Yeah, thank you for complimentary. I have to be humble. I just inherited because that programs I inherited from seniors thinker. Yeah,
ค่ะ
that's
The
to come.
program recruited graduates from other fields like public health, pharmacists, nurses who already practice and would like to enter medical degree ค่ะอาจารย์รามค่ะ
Hello everyone, my name is Ram Rangsin. My background is an epidemiologist, and right now I'm holding the position in the Faculty of Medicine, Kasetsat University. I just early retired from Pramukut Klao College of Medicine, and right now I'm holding the position of head of department of agricultural medicine and bioinnovation in the Kasetsat University. I helping Dr. Sairat, Dr. Korapat to develop their center for academic center for family medicine. Nice to meet you all.
ค่ะสวัสดีค่ะ My name is สายรัตน์นกน้อย You can call me B. I graduated during the time of healthcare reform. Initially, I have an intention to leave medical degree after returning the payback for the government of my medical study. But because of the work in the rural area and the wind of healthcare reform, I have strong interest to provide great care or better care for patients. And that time, during my medical training, we don't have family medicine. And with the healthcare reform, family medicine degree come. And I feel that maybe it's like I can do everything that is like surgery, appendectomy, cesarean section, very good, saving the patients. But I wonder, how come the patients with hip pain never recover and many questions come up? So I think I left my work as a director one day to listen about what is family medicine and decided to do the degree in Pramongkut Klao. Actually, I was in the third batch together with Dr. Korapat. I paid all the 3 years in the rural area, and then Dr. Ram was in the epidemiologic unit. And actually, during those times, we don't have much support. Our teachers are not family physicians. They're trying to do their best to provide us an opportunity to learn. And then I found, oh, Dr. Ram, this guy is great. He is a great teacher, and I like him a lot. So I did some. I think eventually my study is due to my interest in research. The 3 years in medical training, because there is not many people teaching. I I translate motivational interview or the project match of the NIH, and we implemented it as we did an and translate motivational interview into Thai and implemented it for alcohol drinkers because of the project match and as a randomized control trials in seven communities in rural area, although my study was in Bangkok in Pramongkutklao Hospital. So that's where I gained interest in research. And then I did studies in health services research in London School of Hygiene and TropMed, believing that this is important for the development of primary care system in Thailand. So I worked in medical education center for a number of time and then resigned from the government, seeing opportunities with Population Services International, which is an international NGO, US and UK together, that do social franchising, improving health services for primary care units. And then need to find another job and was with Peace Corps. I don't know if you know Peace Corps by JFK. Was with Peace Corps for 6 years and now on my way to improve the situation for primary care and implement great primary care. I'm back to the government after COVID-19 because we did some proposals to the majority and this fixed the problem of health system crisis in Bangkok. And we have many studies, but we didn't manage to publish internationally. We are too busy to do that. And we have another important study that we implemented primary healthcare theory of change, the levers of WHO, the strategic and operational levers, and I can show you later in our discussion what we did, and that's another big study, and I think at the moment we know what we need to do, and that includes changing certain training in our current training that everybody thinks is good. I think there is a lot that we still need to do. I was with the Royal College for 10 years. And I was like chief of the scientific section and vice president, 6 years as vice president and 6 years as chief of scientific section because some overlap in that. I'm running for president of the GPFP Association of Thailand. The election is coming on the 27th of February. We don't know the result, but our work with Family Medicine Academic Center will continue to implement strong primary care system for Thailand, including primary health care. I think in Thailand, they understand more what primary health care is, but not as well for what primary care is.ค่ะ. They know what primary PSC, but not primary care. The majority. Thank you. It's quite a long introduction, but would like to say, just to catch up on what we are going on, what is happening here.
Okay, let me explain myself. My name is Gorapat. You can call me Nat. So I met like Brian and Justin, like I think like before the COVID-19, that I have a chance to visit the OSSU in the primary care units, and we had a good talk, meetings there like a couple years ago, right? Maybe 5 or 6 years ago. And by my training, I'm the same cohort with Dr. Sairat. And then after I finished, I go back to the US for my further study in research. So basically, not only I'm a family doctor, but I work on research on population health. And more closely in the past 10 years, I focus on lipid metabolism. So kind of family doctors and scientists at the same time. So mostly I focus on NCD, focus on diabetes, hypertension, but more the aspect of lipid metabolism, meaning that I work on laboratory, I have a bench work, I have wet lab, so that I can understand population. And in the past 10 years, I have luckily enough to create a cohort, so-called Sirat Health Study. So I have a population health cohort that consisting of about 7,000 healthy workers in hospitals, and some of them is the patients in proximity of the Sirat Hospital. And it's the nature of the cohort. I started cohort 10 years ago when I moved back to Thailand. So now the cohort is about 10 years old. We have information from demographic information. And luckily, in the past 5 years, we enrolled the cohort in Genomics Thailand. In the past 5 or 6 years, Thailand luckily is to have governmental grants to run Thailand Genomics to run for 50,000 Thais for whole genome sequencing. And part of that, I have a chance to give the samples. So now I get the whole genome sequencing back. I get the microSNP array back to understand polymorphic variation, to understand the whole genome, understand the prevalence of the disease that behind genomics in my population. And in the past 5 years, not only I focus on clinical work with patients, I focus on diabetes remission program, like a service program. So I successfully, not successfully, but my team successfully to understand diabetes remission program. And that is a part of clinical work. And in the part of genomics medicines, I'm start to explore understanding about genomic medicine in NCD, like familial hypercholesterolemia. So we published a couple publication in the last 5 years about like FH, NCDs, and we're gonna touch base on pharmacogenomics in the next coming couple years from now. So it's kind of more serious work on genomics. And now I'm, another programs I'm studying in master degree program in Cambridge in UK now. So it's like a still continuing learning for what I'm doing. And we collaborate with the Family Medicine Royal College. So I'm a member for with the Royal College. I think more than not 10 years, but more than like 8 years now. So I work like help them to create a program, especially for the National Conference of Family Medicine program that we have. I'm being held with a head of the national program for 2 years. So I gain more experience on managing, the conference and also work with the residents. So we have residency training in Thailand as well. So I work at the with like combined with clinical work, service work with residents, and also research. Thank you. I would guess that we have some time. So let's we go over with OSSU first to say something about your plan. Maybe takes about like 10 minutes and then move back to Thailand for another 10 minutes and then we can discuss further. Yeah, over.
That's good. Thanks, Dr. Korpat. And we have some slides that we prepared actually, and I'll share if that's okay.
Okay, sure.
Um,
Sure.
and then Jen, I think Jen is going to kind of narrate them for us. So I'll share those right now. Give me 1 second, please.
Yeah.
Hopefully you guys can see this. Great.
Yeah.
And
Yeah.
Jen, I'll let you take it away if that's okay.
Sure. And please feel free to interrupt with questions. I just see the slides and you, Brian. So if anybody else has questions, just shout them out. So we were just going to talk a little bit about our experiences here in the department and with some of the work that I've been doing specifically with practice-based research networks or PBRNs. So again, just we can run through this quickly, but introducing our department and the origins of PBRNs and some lessons learned. And then I've recently received a Fulbright Global Scholar Award, and I'm going to be working on expanding PBRNs in different countries around the world. So hoping that this is of interest to you and a potential collaboration with you. Here we are. I'm Jen. You met Justin, you met Brian, and we're thrilled to be here with you and hope to continue working with you. I think at least one of you mentioned visiting OHSU, so you may know this about us, but just wanted to remind you of our size and that we are the academic medical center for the state of Oregon. We have over 500 beds in our hospital. We have a children's hospital, a lot of research, very large school of medicine, also a smaller school of dentistry, nursing, pharmacy, and public health, over 20,000 employees. 6,700 students, 3,600 faculty, and over 1 million patients visit our institution in a given year. Our medical school is a 4-year training program for the MD degree with 500 students across the 4 years. And then OHSU Department of Family Medicine, our department is one of 27 departments in the School of Medicine. So again, a very large medical school. Family medicine is one of the 5 largest departments. We provide a lot of clinical care. We provide full spectrum care. We have hospital services, adult and pediatrics, outpatient clinics, obstetrical services, 12 primary care clinics in various parts of the state, and also immediate care clinics, over 200 faculty that work directly for the department, and then over 300 volunteer faculty across the state of Oregon, and 100 family medicine residents, 5 residency programs, lots of medical students working within our department, and students from other disciplines, physician associates, nurse practitioners, social workers, nurses, midwives, pharmacists, many other disciplines, and also a sports medicine fellowship in addition to the residency programs. We have at least 14 full-time research faculty, a number of others that do part-time research, and a large staff supporting them with a focus on healthcare transformation and innovation. And we've been consistently ranked in the #1 or #2 slot for family medicine departments across the United States. So we're very proud of being one most of the
Congratulations.
time. Yeah.
It's a big campus.
It is a big campus, yeah, and it's growing. We have another building that they're just about to open on our campus. So this is a picture of our collaborative sciences building, actually, with people walking on all these different levels. And many different students come together to learn in this building from, again, pharmacy, medical school, nursing school, public health school. But we've been really involved for a very long time in practice-based research networks, and focusing them really in primary care clinics and primary care practices, knowing that, you know, health is better in areas with more primary care physicians and people who receive care from a primary care physician, whether it be a family doctor, or in our country, we also have internal medicine primary care doctors and pediatric primary care doctors. People receiving care from those primary care physicians are healthier. And Barbara Starfield years ago did a lot of work internationally showing that countries around the world and societies with strong primary care have better health outcomes and lower costs. So really focusing our research in the areas in primary care where populations are healthier, because most biomedical research traditionally has been in large hospital settings and not in communities and not in primary care settings where a lot of people receive their care. So we've been focusing on building partnerships between our researchers and our primary care teams. And that's been the focus of my research and what I've been really excited about doing for a very long time now. So the practice-based research network that I helped to start is in partnership with OCHIN, which was an organization that started as the Oregon Community Health Information Network. And you'll see this map of the United States. It's now grown far beyond Oregon. It's in a number of states across the country, and it's a network of primary care community clinics that have one linked electronic health record. So the data from clinics in all these states across the country is housed in Portland, Oregon at OCHIN's headquarters. And we started partnering with them in 2010 to grow this very large network now that has over 2,000 clinics and 6 million patients. And we were really hoping to provide evidence-based research that was applicable to busy frontline primary care practices. Worked with the Patient-Centered Outcomes Research Institute, founded after Obamacare was passed. That organization started and was very focused on building large networks to do patient-centered outcomes research. So we got one of their very large grants to start what's called the Advance Network. And really using our practice-based research network now as a primary care laboratory, we've been conducting intervention trials, developing new methods, doing health policy research, health equity research, implementation science, health services research. And a lot of our studies are randomizing at the clinic level. So instead of recruiting patients and randomizing patients to receive different interventions, because we have 2,000 clinics, we can recruit clinics, and different clinics get different interventions. And so that we can test new ways of delivering care or new tools in primary care setting and help to improve care by doing that type of research. I think, oh, and then this also, what we were really aiming to do was kind of hit what we call the sweet spot here in the middle of what our practices really wanted to do with quality improvement and implementation of health information technology, their team-based care, clinical decision tools, the personal medical records. All of that was happening. And then we wanted to say, well, you can really combine the tools and the infrastructure you need to do practice transformation. You can also be doing research. So we have now electronic health record data, registries, the infrastructure, the methodologies, the data expertise in order to inform practice change, policy change, and really disseminate findings from studies that are done using very robust experimental methods, research methods. So that was our vision in building this network of community health centers. And it's really been very wonderful to see so much research happening that's also been improving care and impacting how these clinics are operating. And what... Did you have a question? Oh, okay. So one of the things that we started in primary care is this notion of a patient-centered medical home. And it was really just creating a primary care clinic that has all these other features. And then we took it to this next level of you would have a patient-centered medical home or a PCMH. And if you combined a whole bunch of them, and then you also brought in public health and some of the federal and state offices, that you could create this patient-centered medical village. So bringing a lot of these PBRNs, or what we were calling community laboratories, together to support these very large research studies. And so that was really exciting. Again, our vision of creating this patient-centered medical village. So a lot of my work over the last 20 years has been focusing on this national network. And it's been really exciting to think about going global and bringing the notion of PBRNs to other countries around the world. And we really had this idea several years ago, and others have been approaching us from Japan and Nigeria and the Netherlands. And it's coinciding with the World Organization of Family Doctors, or WONCA, is very interested in creating a global PBRN initiative in partnership with the North American Primary Care Research Group, which I've been involved with since I started doing research as a resident. So there's, I think, a lot of synergy now between the work that we're doing and what we've learned, and then what some of our international organizations are very interested in with the Global PBRN Initiative. So I'm really excited about the Fulbright award that I have received to work specifically in Japan, Nigeria, and the Netherlands. But I think there's just so much going on everywhere else. So really excited about what you're doing in Thailand and how we can work together. Again, so potential collaboration. So want to look forward to what you have to teach us, and that I think that both of our countries have a strong primary care foundation and a commitment to family medicine and community-oriented care. So I think there's a lot we can learn from each other, bi-directional collaboration and learning. Just really also looking very locally into how to generate evidence that's applicable to our local settings, but also that we can disseminate on a global scale. So what we learn in the United States or in Thailand is going to teach many other countries in improving their primary care system and training of family medicine teams, and informing policy that's grounded in practice. It sounds like what you've been doing as well is really understanding what it takes to train the workforce and then keep people in the communities to serve the populations. And again, the timing is wonderful, and all the connections that you all have built, we can build on those further. And how do we grow these existing partnerships and start new collaborations? Thank you very much. Look forward to learning more about you and your teams.
Thank you, Jen. This is wonderful presentations and make us understand more about OSSU that I know of OSU for a long time, but let everyone understand it. We have a lot of improvement in terms of collaboration, in terms of research network in Thailand. That's how I invite everyone from Thailand and to discuss with you today. I think we have a wonderful work, especially Dr. Sairat Noknoy, who is actually studying the we call so-called the FMAC. So let Dr. Sairat present on our end from the Family Medicine Academic Center that in collaboration with the Royal College of Family Medicine. อาจารย์สายรัตน์ครับ
ค่ะขอบคุณค่ะ um, thank you for the presentation. I'm really thrilled about what is coming up, the collaboration that and the potential that we are growing together. Just as you may know about the Royal College of Family Physicians of Thailand, is one organization with this logo on the left. The Royal College is bound to the Medical Council. And then we don't have a real legal autonomy to do business, like contracting or collaboration, if there is legal or accepting funds, for example. And there is another organization which is called GPFP Association of Thailand. Actually, the training as a board training for GP occurred since 1971 as a specialty training. We have the board training for GP very long ago. And then the first batch of this training formed the association. And then during the time of healthcare reform, they see that it's hard to make people recognize the GP specialty and transform into family medicine. So that's how we have the the Royal College of Family Physicians of Thailand. And I initially started to be based to work on the Royal College part, and then find that there are a lot of struggling when we do research and when we need to accept funds from organizations. And actually, the association can have more voice as a professional voice as well. So I see potential to join together the two organizations. So FMAC is a bridge between two organizations to grow knowledge from the field, from the community. Because we need to be honest, most of the trainees are trained here in Thailand, are trained from the hospital system. Even the trainers don't see the whole system because some trainers come too early before being exposed sufficiently in the community to understand it. So FMAC is to bridge the community piece, the work in the front line, together with training institutes who are equipped with training capacity and research capacity. And so this is the objective, as I mentioned earlier, and we receive grants from Thai Health and from the Health Research Institutes to do our work. And the research and work that we do are from various funding, including some substitutes funding from the Royal College and the GPFP Association, in order to grow the knowledge in the field of family medicine. So our strategies is to strengthen academic institutes or people who are interested in certain fields. We started to develop the node or training institute to be involved in research for the community, and it's located in various parts of Thailand. And the FMAC plays as a focal point to bring together. So if we do research at various sites, we can manage to have in various different parts of the country with the same interest, maybe interest in the addiction, interest in the palliative care or diabetic care, for example. So notes can be either by region or by area of interest, gathering people with same interest to work together. And we have three big research from the central team. That is the number first and number second is from the implementation that we did, and Dr. Ram lead the cohort study. I don't remember, it's like 100,000 or how many people in your cohort of COVID that time เท่าไหร่นะคะอาจารย์ราม
90 90,000.
90,000 people in our cohort from COVID-19. And this first one is a cohort study of our implementation during that time. And this one is the implementation research of what we did. We used code cipher in the evaluation of our implementation. It's completed, but we don't have time to publish internationally. We wish to be able to publish it anyway. It's like, is it unethical if you don't publish? But we know what to do. And then the other is the recent one is strengthen primary care system through using the knowledge in family medicine. I would need to be honest. Our family physicians are almost 99% in hospitals, are hospital-based. Practice-based practice. We might have primary care practitioners who are really in practice in primary care in Bangkok, but they are not family physician, do not deliver care that people trust yet. So from work in Peace Corps as a Peace Corps medical officer and from PSI, we know there is a lot to do in terms of improving, strengthen this practice and bring recognition to the population. In these studies, we use primary healthcare theory of change. I won't go much into detail about this. I think you know what it is in your how to improve. And in COVID-19, in Bangkok, people die in the street. And people are using, the government has a campaign called home isolation, but nobody talk about family physicians. Nobody thought about primary care. So we came out and I worked with Chris Van Wil and Bonga a lot. And I learned from the review of our work together what they did abroad. In the Philippines, they call for volunteering. So bring all those knowledge. And we call for volunteer, health professionals volunteers. And we have like 3,000 volunteers who join us in solving the problem of health system crisis in Bangkok. And we told the policymakers, we have warm community clinics. They are shut down. There are health professionals that don't work that time. We need to bring them in, do home isolation and do community service that are needed. And we know that we need to develop a standard procedure, develop guidelines that are specific to primary care. And then because we don't have a clinic ourselves, we are Royal College and Association, we know that there are some other initiatives. We match with them and let them be an outlet to provide service to the population. So we have like service through community clinic that we have guidelines for them. And then among these volunteers, we think that some of them might be providing services. Some of them might be providing consultation. We have other specialists, not family physician and family physician specialists who provide consultation, those who are receiving cases. And we also have nurses, psychologists, social workers, physical therapists joining in this initiative. So that initiative managed to solve the problem of crisis in Bangkok, bring people who need respirators into treatment, even respirator treatment at home during that time. And we save a lot of lives from those times. And then I would like to go more into detail about our recent studies because this is what we are moving forward to the future. This is an implementation research, strengthening primary care system through the concept of family medicine for health promoting hospitals. Health promoting hospitals are not hospitals. They are health center. Mostly they don't have practice of medical doctors, but they are the backbone of primary healthcare system of Thailand. Under the process of decentralization to provincial administration in Thailand. The health centers were originally under the Ministry of Public Health, but with the Decentralization Act, they need to move to the Ministry of Interior. And because of power orientation, the Ministry of Public Health doesn't support this decentralization process, and that make a lot of mess to the health system. So in these studies is our group, and we use this is the study that was presented in Wonga, Lisbon. So Thai health system has health promoting hospitals that serve as primary care units and integrated function is an integrating function between primary care and public health. The strength of our system is that it's already integrated. We have public health professionals in these HPH units or primary care unit. We have nurses. We have nurses in most of all HPH units, and it's function in every sub-district in Thailand. So it's the backbone of the system and is under the public sector. It's public. And then the main structure is the main structure of primary healthcare system, initially operated by the MOPH. The Reform Act led to the structural change that the governance of PSC system. So we aim to bridge everything together and understand, use the principle of family medicine to to help solving the conflicts. And we use the primary healthcare theory of change and the 14 levers, the 14 PSC levers, in achieve what needs to be achieved for the health system. So we in the strategic levers is like the political commitment, both at national level and at local level needs to be people need to be engaged. People in policy makings need to be engaged. Funding allocation and engagement of community into planning of policy, either at provincial level or either at national level. And then the operational levers is about the practice work, what needs to be done is like the model of care, improving the capacity of workforce, infrastructure, and medical products that need to be in place, and engaging of private sectors, and improving purchasing and payment mechanism, and using digital technology, improving the system for quality of care, and using primary healthcare oriented research and monitoring and evaluation. So from those 14 levers, we simplify into 4 key activities into our implementation. The first one, I think, is matched which Brian mentioned in the beginning. I think you mentioned about building leadership, right, for people. So we know the limitation of family physicians in Thailand. They are good clinicians. They are good clinicians, but in their mind now, families they are more interested in geriatric, being a family medicine physicians who are specialized in geriatric, or either specialized into palliative because they want to be recognized as other specialists. So family medicine itself has been devalued, and they don't understand the whole system or community practice as much. So we think we need to build capacity of family physicians, bringing them knowledge about the system, what system is and what primary healthcare system actually is, and building the capacity to do research from the place they work in their career. Here in this, we implemented research skills and knowledge about system and primary healthcare system, including leadership is part of this as well. So, and to increase the number of more primary healthcare oriented research. The second activities under this research is engaging policymakers either at province level or at national level. Our study was implemented in 4 provinces. One province in the north is Lamphun, and another province in the east, Tak province in the border, is north as well. And then in the northeast is with Khon Kaen province, northeast. And then in the east shore of Thailand is in Rayong province. We actually would love to have Hat Yai as well, but we didn't achieve to have them join because we need the family physician leaders to be engaged. We achieved to have 4 provinces engaged. So in this blue one is a participatory action research. It's a PAR. participatory action research, engaging policymakers and engaging voice of the community or voice of the society. It's like community leaders into the conversation of how we should help improve the situation of conflicts now that the health HPS are transferred. Some provinces we see strong conflict, like in Lamphun, that the Ministry of Public Health is not supporting. But there is a strong political views of local politicians into improving. So we try to understand what is happening during this transition. In the Northeast, it's like so. It's like, okay, we see a lot of potential to move ahead together and improving. But there is like confusion because of what is happening. And then in the East Shore, we see strong collaboration between Ministry of Public Health and we have family physicians leaders engaging and trying to bridge understanding and supporting this decentralization process, making this system of primary health care transition smooth. And
Dr.
then so,
Dr. Sairat, I'm sorry to interrupt. I just had a quick question for you. We're getting close to time. We have about 12 minutes left. Unfortunately, I was wondering if we could maybe take some of these great points you're making and have a conversation together for the last 10, so we can actually talk about ways we can address many of these great points you're making.
Okay. Just shortly, the pink part is the primary care service. Improving the quality of primary care service is the service itself. It's the service itself. So it's the operational lever. The blue part is the strategic lever, and the pink part is the operational lever. And then this one is the monitoring and evaluation. We use the PCAT to evaluate and do baseline evaluation and use evaluation of the service to primary care, how it is, and we see the result. The result shows the gap that we are not achieving what needs to be achieved by PCAT, as well as by clinical indicator that we are not achieving what we need to achieve. So that's shortly about what we have. And then just to let you know, we are also having conversation with Kew University with Professor Christian Malen from National Institute of Health Research, UK, and they came to Thailand in December, and we are forming collaboration to grow this together. And having you today from in the second phase, we are implementing the system in two main provinces, Khon Kaen and Bangkok, because there are highest potential to implement the primary care practice to be real or the system of primary health care. So Khon Kaen will demonstrate both primary care and the system in city and in a rural area, in urban and rural area. Bangkok will demonstrate how the system should be like in urban area. So that this will be the two fields that we are focusing, and then we are supporting.
We lost you there, Dr. Sairat.
Posting.
Results.
Oh, you're
That's
back. Okay.
Okay. ครับ
Thank you so much.
I think we see the same vision together with about primary care research network, not only just family physician, but also maybe the primary care system in the future time. So I'm open for discussion about how we can move this collaboration further. Any thoughts on that?
Well, before we say, I want to thank you for that wonderful presentation, Dr. Sairat. It was really, I wish we could have had more time to go through the last few slides, especially really interesting work you're doing and just very exciting. So congratulations on your progress. And it's just delightful to see your connection with, especially with the provincial health offices and the public health sector. That's fantastic. And so congratulations on your progress there. I think in terms of our time remaining, because because of what Jen presented too, Jen, could you maybe explain how Nigeria and other countries are joining some of the work that's happening in the U.S.? How are you collaborating with other countries? It might be a good roadmap for us as to how Thailand might be able to work with us too.
I'm just getting started on some of the collaborations, so I think every collaboration is different. Japan, it really started with the training programs. So really wanting to understand family medicine and how to build training programs for students and residents interested in family medicine. And then that grew to the research network that we're working on with them now. So a little bit, I think, somewhat similar to where you are. And I know you're doing a lot of educational programs. So are there places where there's also the ability to work on research together? Nigeria, it's really been modeling some of the training and the research we're doing within the Ocean Practice-Based Research Network. They came and wanted to build an implementation science center specifically that was similar to one that we had built. And there were a number of grants that the National Institutes of Health in the United States put out for partnerships specifically between US institutions and institutions in lower income countries. So we got a grant with Nigeria to work on a specific primary care public health community-based study. I don't know a lot about the future for some of those grants, but it's something to keep an eye on if there are opportunities either with US funders or TRI funders or international funders that want partnerships between universities in different countries. But that's what kind of started the Nigeria partnership, is they had work going on and we had work going on, and we identified a grant that we were able to apply for, that we obtained funding to do this study together.
Yeah, actually, then that is a great point to start on the training, because I think there is already a lot of reform that we've made inside ourselves of the training mechanism. It's like we found that it's like there are board exam for people who come into training, and board exam for people who are not in the training but they study themselves. I think we see pretty clear. I personally see that people who don't come in the training, they are very strong without any training, because they expose the real system, the real practice, and but the door is closing of the Thai system. The Thai trend is closing, but we need to elaborate on that, and we really need to engage more the people, medical professionals who graduated, newly graduated, who are still not thinking about family medicine, struggling in their practice, into supporting them and then engaging them. So there will need a lot of reform within our training mechanism, and that would be a great support from you. But I would need to be honest, before this, at Wonka last year in Lisbon, Toronto came to discuss with us as well. So it's great to have so many peers and so many people coming. So we will need to map which one we will working on which part, but we haven't seen the detail with Toronto yet, because it's like standing discussion on possibilities. And with you, what you mentioned and what we see, a lot of your work is very much in line, and we see potential to start with that as well. ค่ะ Dr. สุภสิทธิ์ค่ะ
Um, I, I saw that you have the Fulbright grant. Would that fit with Thailand framework, or you have to apply another?
Yeah, there's always the opportunity every year to apply for another Fulbright grant in any of our, I don't know all the opportunities for which Fulbrights we could apply for and how we could frame it. But yeah, the one that I applied for, I had to have letters from those three countries, Japan, Nigeria, and Netherlands, in as part of the application. So, but we could look at that for future years. Absolutely. I think that would be one way to really expand on the collaboration, would be to identify if there were places in Thailand where you wanted people from our university to come and spend time teaching or conducting research. We could definitely look at the Fulbright as an opportunity to apply for that in the future.
Dr. Supasit, I
อา
think
จารย์
you
ไม่
may
ได้
be
เปิด
mute,
ไม
you
ค์
may be
ค่ะ
muted.
Yeah, that's because we have just 2 minutes left. Then we may
In a bit,
continue
yes.
our next meeting with these kind of proposing to the Fulbright.
Yeah, and you mentioned Chris Van Wiel. He's my collaborator in the Netherlands, so I'm glad you're connected with him. Are you also connected with Anna Dania, who's doing the global PBRN initiative with Wonka?
No, I was very busy I was in the Wonka Working Party on research, met Chris Van Wiel since 10 years ago, and then have been working with him on papers, a couple of papers, and then communicating with him every time I went to Wonka. And I work closely with Felicity Goodyear-Smith. And Felicity, we work on the Global Core Value Project, and I'm the lead for the regional APR region, the Wonka Core Value Project, and a number of we are doing review of primary care and family medicine development APR book, and also at the edge of that. So Chris is like my informal mentor. When he met me at one time, he said, "You are the technology." He come close to me. What is he doing? Is he courting me or what? It's very strange. But then I asked him in recent Wonka. He says he sees something in me, and he really believes in that. And I think when your presentation, he told that our lab is the community and the PBRN.
That's
Yeah.
great.
I'm glad you're connected to Felicity. She does great work.
Yeah. We worked together, and he told me he originated Nutcrack. And then I was thinking, is Brian in the Nutcrack? Maybe your face look familiar with people from Nutcrack that come to Wonka, but I don't know. I haven't been connected because now I have two full time on the work that I didn't intend with DAS, Division of STI. So very busy, but need to go at night as well. So I think thank you for the fruitful discussion. It's very exciting. I'm really thrilled with this coming up. See a lot of potential. Thought of Fulbright, but I thought, oh, would that be too obvious in our first discussion? Yeah, but we are thinking about writing Fulbright together and then see mapping which piece who we go with whom. I also met Kara Hansen during this couple of weeks. She's the dean of our SHTM. Introduced myself to her as a past alumni, and I really love health economics during those times, although didn't intend it. So thank you for the meeting, Dr. Korapat. Thank you for bringing this to Thailand, by the way.
Yeah, sure.
Thanks,
Not the
Amilu.
ending. I just want to say so. What would you think is our next step? So that I don't want like this conversation today just go away. Then what, Justin? Do you have any thought that what is our next step that in terms of more detail?
Well, I'd love to hear. I know we only have 1 minute, but first of all, I can see why there was so much energy with Dr. Sairat too. It's obviously you have a passion for this, and it's wonderful to meet you and hear more about the good work in Thailand. I was wondering, Jen is going to be spending maybe some time traveling. One option is that maybe we see what her travel schedule is, if she can include Thailand, and maybe come to visit in person with you to learn more about your needs and to see what we can do for next steps. That's one option. The next is maybe to sort of see what comes from, if you can't get to Thailand, we could still have a follow-up call to sort of talk about next steps for the Fulbright idea. That sounds like the most interesting area, is to include Thailand with the Fulbright. So if we can't get her to Thailand, we might be able to get her to another call, which just talks about the Fulbright process that we could apply for together and help support whoever wants to be on that application. What do you think, Jen?
Yeah, I think that's great. I don't know as much about the Fulbright as I probably should because it's such a big program, but we could all learn together what some of the opportunities might be. And I believe that the deadline for most of them is around September for the following year, so we could work between now and September. But again, I kind of stumbled into this one opportunity because I wanted to go to more than one country. Most of their applications are one country. So if the one country is Thailand, then I think we could absolutely go for that. But if people want to combine work in Australia, or I forget where else you said, Japan, other places, we can kind of see what else is in there. But
Do you think in 6 months will you have more to share with us about the experience? In 6 months, when would you be ready to talk more about the experience that you've been having gone through it?
Well, I mean, I'm starting in Japan, but I don't start until May. So I think the best way to learn about it is to go to the Fulbright website and really just start exploring what other opportunities are there. And again, I don't know about any of the other opportunities. I just found out about this one.
Okay, Corapot, what would you like to do? Would you like to have a follow-up call we can put in the books for several months from now, and then we can do some research? Maybe Brian and I can take more of a look at the opportunities, and we can
Yeah.
prepare for the call to talk about how we can use the content of the presentations today to look for synergies for next steps.
Yeah, sure. Yes, I think maybe in 2 months from now, maybe this January, right? So maybe we schedule for in March, over the loop in the email. And I think apply for the grant is good, really good opportunity for everyone here, right? But I think I would think something short term or something that we can start at this moment, like a research network with primary care or anything, between two countries. So I think maybe we're thinking about like something short term, intermediate terms, and long term. I would say that, right? Maybe we do a follow up in next 2 months. Dr. Sarat, do you have any idea? Dr. Ram, do you have any idea?
Just thank you ค่ะ I think follow-up call I think if either you come or we have a second follow-up call in March and then we communicate via the loop of email and we exchange our slides and the work that we have done or what would be beneficial to help understand about each potential ค่ะ
Dr. Brian, do you have any thoughts on that? Like a last minute thought?
No, that plan sounds really good to me. And like Justin mentioned, we're happy to do some background research on other funding opportunities in the meantime. And who knows what we can dig up. We usually will turn over every rock and stone to see what we can find. So very excited to about this. Yeah.
I'm going to Iloilo Wonga Apia. Would you
Philippines.
mind if I mention about the collaboration that is growing here? But other countries, I think they are already advanced more than us by any means. But we'll
Just
share
started.
and see.
Good.
Perfect. That sounds wonderful to me. And we'll talk to Jen offline and come back to you before the next call with potential ideas for the agenda so we can keep the conversation going to see if this has legs and has momentum moving forward. How does that sound?
Okay, good. That's good though. Okay.
Good.
So I think
Excellent.
we have a fruitful discussions today. Okay.
So good night for both
Uh,
Cambridge and Oregon.
yes, get
It's
some
two
sleep,
o'clock
Thank you
today.
Corapont.
for the wonderful discussion. I
Yes.
will hope I have good day at work. It's always a good day anyway.
Okay.
Thankครับ
Thank you
นิ
ขอบคุณ
everyone
ครับ
ค่ะ
Thank you everyone.
ขอบ
Thank
คุ
you
ณ
so
มาก
much.
ค่ะ
สวัสดีครั
ขอบ
บ
คุณอาจารย์สุประสิทธิ์ขอบคุณอาจารย์รามขอบคุณอาจารย์กรพัฒน์นะคะ
ทุกคนครับ
Thank
Thank you
you
very much. Have a good day. Good night.
Thanks, everybody. Thank you, Jen. Thank you, Ryan. Sorry, Club.
สวัสดีครับ
Thanks, everyone. Take care.
Bye.